I'm going to speak today about non-opioid management of chronic pain. This does not mean that opioids don't have a place in chronic pain management, but an awful lot of pain, if not most, can be managed with non-opioid options. So a little bit of a definition of chronic pain. Chronic pain is really pain that persists for longer than 12 weeks. Pain that is shorter in duration would be considered acute or subacute. Some definitions would say 24 weeks to define chronic pain, most say 12 weeks. According to the Centers for Disease Control and Prevention, roughly 20 million Americans are affected with chronic pain. Some associations or organizations would say that this is an underestimate, but this is the CDC's estimate. Chronic pain really is among one of the most common reasons that adults in our country seek medical care and medical treatment. Chronic pain is associated with a decreased quality of life. A lot of patients that are affected with this say that they just struggle to do the things that they want to do. Some of them can't work. Some of them feel really very limited with what they're able to do. It's also associated with opioid dependence and can be associated with poor mental health. Does not mean everybody with it has poor mental health. It can be difficult to treat, and it can be difficult for people to understand. People don't always accept that someone has chronic pain. They think you look fine if you don't have a bandage on your head or a cast on your arm, but you can be suffering with chronic pain, even if it is not apparent to other people. Chronic pain really can be an economic burden on the country. It is considered to be a very significant reason for lost productivity in our country. In 2010, there were estimates that the days of work missed due to chronic pain resulted in $11.6 to $12.7 billion of lost revenue. Hours of work lost due to chronic pain was estimated to cost the country $95.2 to $96.5 billion. So it can be an economic loss and definitely a quality of life issue for people. Opioid prescriptions have been used to manage chronic pain for some time for various reasons. In the 1990s, the number of opioid prescriptions given in the United States increased really quite drastically, quite dramatically. Opioid pain medication use presents serious risks, specifically the risk of overdose and opioid use disorder patients. Between 1999 and 2010, prescription opioid-related overdose deaths increased in parallel or in line with increased prescription of opioids. There's definitely a direct correlation there. In 2015, opioid-involved drug overdoses accounted for over 33,000 deaths in this country. 1/2 of those involved opioid prescriptions. Opioid prescriptions peaked in 2010. Since then, they have started to decline. Some of that is because we've started to try to educate physicians and providers more about appropriate use and the crisis that we're facing in our country. However, unfortunately, opioid-involved overdose death rates do continue to rise. These increases are felt to be driven by the use of illicit opioids, such as heroin and illicitly manufactured fentanyl. The increase in illicit opioids and high levels of prescription opioids are definitely related. Changing prescribing practices is an important step in addressing the epidemic that we have. Reducing inappropriate prescribing will likely have an important impact. There are strategies to manage chronic pain without opioids or managing chronic pain with limited opioids. Opioids should not be used as a first-line therapy in chronic pain, and this is in chronic non-cancer pain specifically. Cancer pain has some different guidelines. There is no evidence showing long-term benefit of opioids in pain and function for chronic non-cancer pain. That is a statement directly from the CDC and is also supported by the NIH, or National Institute of Health. There is little to no evidence of a positive effect for opioids chronically for non-cancer pain. Does not mean that some patients don't benefit from them and don't need them, but this is just the data that the CDC is telling us and that is supported. Common types of pain, we can categorize pain in a number of different ways. Low back pain really is not in and of itself a diagnosis, but it is the most common reason that people would seek management of pain in this country. So common reasons why people would come to our clinic or seek treatment for their pain would be low back pain. The next most common would probably be neck pain or arthritis, headache pain, fibromyalgia, neuropathy. What I mean by that is pain of the nerves and muscle pain. So when we see a patient with chronic pain, some of our patients have been worked up well before they come to us, others have not been. For certain patients, we require a workup before they come in, specifically abdominal or pelvic pain. We want to make sure that we're not missing something before we see them. For back pain and neck pain, a lot of times we will work that up in our clinic. But this is just kind of a little bit of a synopsis of how you would work someone up with chronic pain. We would want to assess where is their pain located, when do they have the pain, describe the pain, are there factors that make it better or worse, or activities that make it better or worse. We would examine the patient. We may order tests such as lab work or EMG. EMG studies can help determine if there's nerve damage or nerves being pinched or compressed someplace. We order a lot of imaging tests, specifically X-rays and MRI scans. We may or may not order CT scans depending upon the patient. So this is just a synopsis or gist of how we would work up the patient, because the first thing that we want to do is identify what is the cause of pain so that we can better treat the pain. So after we assess for what is most likely causing the pain, then we discuss a treatment plan with the patient. There are a lot of ways of managing chronic pain. For some patients, one means or one modality is enough. For other people, it's not. Some people need a multimodality to manage their chronic pain. Physical therapy is one means or one modality. It's probably one of the first means that we start with to manage chronic pain. Physical therapy is really a medical treatment used to restore functional movements, such as standing, walking, and moving different body parts. It can be effective for injuries resulting in pain, movement dysfunction, or limited mobility. The main goal or the ultimate goal is really to teach the patient how to prevent injury, manage pain, and restore functional movements. The physical therapist may use a lot of different means or modalities. Commonly, they'll use exercise, joint or tissue mobilizations, and a lot of the physical therapists that we send our patients to do some dry needling, just putting fine needles into tight muscles or painful areas of the muscle. A lot of our patients also seek chiropractic care. Chiropractors perform adjustments to the spine or other parts of the body. The goal is really to correct alignment problems, ease pain, and support the body's natural ability to heal itself. Some chiropractors will offer, dietary supplements, recommend relaxation techniques, or lifestyle modifications. We do send some of our patients for acupuncture. We don't have an acupuncturist in our clinic. Sanford does have two providers who provide acupuncture. We have a chiropractor who performs acupuncture, and we do have a formally trained acupuncturist working in the integrative health department. There are some private acupuncture groups here in the Fargo Moorhead area in addition. So acupuncture is a traditional Chinese method used to relieve some health conditions and symptoms such as pain. It can be used to treat other things beyond pain. But fine needles are inserted into the skin at multiple acupoints, and the thought or theory behind it works is that it's prompting the body to release natural chemicals to fight the illness or symptom. In our clinic, we do a lot of interventions or procedures. Myself and my colleague trained in a lot of these interventions and procedures. It does not mean that that's the only way to treat pain, nor does it mean that it's the only way that we think pain should be treated. It's just a good portion of what the physicians in our clinic do. Again, not the only thing that we offer. So I'm going to go through some of those procedures today because I get asked a lot about these procedures. And like I said, it's a significant modality or means for us to treat pain. So we do offer something called trigger point injections. A trigger point is really a tight band of muscle that's painful. If you push on the muscle, it will cause pain, and the pain may radiate to another location. This is commonly seen in the neck, mid-back, or low back area. You can get trigger points in a number of other areas of the body. So we just insert a needle into the muscle and usually just inject a little bit of local or numbing medication. Typically, we would use this in conjunction with physical therapy, stretching exercises, or massage therapy. We do a number of blocks for head and neck pain. We do perform Botox for migraine headaches. I would say the bulk of the patients that we see for migraine headaches have received this or received this from a neurologist, but we do offer Botox. Auriculotemporal nerve blocks are blocks to manage pain that's anterior in front of the ear if the nerve there is being compressed or entrapped or irritated. And we do pretty commonly perform occipital nerve blocks. The occipital nerve runs really at the base of the skull and neck junction. It provides sensory innervation to the back of the head. These nerves can become entrapped or irritated sometimes after a patient has experienced trauma, or sometimes this can just occur. We do offer something called the sphenopalatine ganglion block. This is a group of nerves basically in back of the nose or nasal region. This is commonly used to treat a headache that's just really very painful and not responding well to other treatments. Normally, we would put a catheter in the nasal area or nose and then inject local anesthetic there. This is typically a block that would have to be offered in a series. We do perform some injections called C1-2 and atlanto-occipital blocks. The atlanto-occipital joint is at the base of the head and the neck. The C1-2 joint is just right below that. So we would be performing these injections if someone has arthritis or inflammation of those joints. And just steroid and local would be injected there. Trigeminal nerve blocks, we do see some patients with trigeminal neuralgia. This is a very painful condition of the face. This can be very excruciating and very debilitating for patients. We don't offer this block at this time, but there is a physician in Grand Forks that we sometimes refer patients to have this injection. Supraorbital nerve blocks and supratrochlear nerve blocks are injections that we commonly use if people have eyelid pain or pain of the forehead from shingles-related pain. You can use this as a block to numb the area if someone has a laceration that needs to be repaired there also. We do a number of joint injections. We see an awful lot of patients with hip, knee, shoulder, and sacroiliac pain. The sacroiliac joint is a joint where the sacrum and pelvic come together. This is actually a very common cause of low back pain. Typically in these injections, we are injecting local and steroid. So most commonly, this would be pain secondary to arthritis, possibly pain that's inflammatory in nature. Epidural steroid injections, this is really our most common injection. The most common area that we would perform this would be for low back pain. But usually an epidural steroid injection will be recommended to treat pain that's originating from the spinal nerve roots. So common indications or things that would commonly cause this would be a herniated disc or a disc that's pushing out. This can cause nerve irritation and can cause inflammation in the area that can be very painful. Degenerative disc disease, patients everyone over time will get some degeneration of their discs. Some people will have pain from this, others will not. If people have a radicular component to this, meaning pain radiating to their leg, chest wall, or arm, we may consider them for an epidural steroid injection. Normally, these injections would be considered if someone has tried physical therapy or has tried other medications. And we just put local and a steroid into the epidural space. So it works by trying to control inflammation and nerve irritation. Again, this can be used at the neck, mid-back, and low back. Transforaminal epidurals or nerve root blocks basically are like a type of epidural, only we specifically target one area. We're really trying to target the foramen, which is where the nerve exits before it's going to the chest wall, arm, or leg. So sometimes some of our surgeons will request these injections for diagnostic purposes. Sometimes we will initiate these injections if we want to be a little bit more specific with where we're putting the medication, or if the initial epidural steroid injection did not help the patient. Radiofrequency ablation is probably our second most commonly performed procedure in our clinic. This uses heat to destroy tissue. For pain management, radio waves are sent through a needle that's placed very precisely. We generally will use X-ray visualization to place those needles or needle. And then a radiofrequency probe is placed through the needle and a heat signal is sent there. So we're creating a little lesion on the nerve. It's not permanent, but this procedure can be repeated. Depending on which area and the patient, some people will receive 6 months to a year. I've had patients that have received over 3 years of relief from some of these procedures. Can be repeated as needed. What we're doing when we create that lesion is we're preventing that area from sending pain signals to the brain, basically. Commonly performed areas would be, the most common would be the low back and neck. This can be performed in the mid back, and we can also perform this for shoulder pain, hip pain, and knee pain, and sacroiliac joint pain. Sometimes in addition, if patients have had joint replacement surgery and they're still having pain, we will sometimes perform this procedure. Other nerve blocks, intercostal nerve blocks, sacrococcygeal ligament injections, and lateral femoral cutaneous nerve blocks. So intercostal nerve blocks, if people have had chest wall trauma, if they have rib fractures with poorly controlled pain, we will sometimes perform this. Sometimes patients that have had cancer or radiation treatments can be left with pain in this area. Shingles pain can unfortunately cause chronic pain in this area that's really quite painful. So those would be common reasons why we may perform these intercostal nerve blocks. Sacrococcygeal ligament pain, we commonly perform for tailbone pain. We just literally put the put the needle right over the ligament and inject local and steroid. And for a lot of patients, it's quite helpful. Lateral femoral cutaneous nerve, that's a nerve over the front and side of the thigh. That nerve can become entrapped or irritated as it's passing from the back into the leg region. And so for patients that have this pain, usually we'll recommend some physical therapy, perhaps some medication in addition, but some of them will benefit from this block. We perform transverse abdominis planus blocks. There are patients that have abdominal muscle pain. This would be the best example of when we would do this. We are performing more cluneal nerve blocks lately. This is for pain of the sacral region and low back. These nerves can become entrapped or irritated. We do see this fairly commonly in patients that have had back surgery that have some residual pain. This can be a common pain source in those patients. We typically perform this under ultrasound. Ilioinguinal nerve blocks. This is a nerve kind of in the lower abdominal and groin area. Sometimes if patients have had hernia repairs, they can be left with residual pain. They can have entrapment of the nerve type syndromes that exist after the surgery. And so sometimes we will get patients referred after surgery that have continued pain. Suprascapular nerve blocks we perform for chronic shoulder pain, typically that is not responding to other means or treatments. And then we have a number of bursa injections. The bursa is just a fluid-lined sac. Areas that we would commonly inject would be the shoulder and hip region. These are just high friction or movement points in the body, and though that bursa can sometimes become inflamed or irritated, sometimes after trauma that can become inflamed or irritated. We do a number of sympathetic nerve blocks. The sympathetic nerves are just a type of nerves in the body, but this system is a network of nerves throughout the body, and it controls involuntary body functions that you have no control over, such as your opening and closing of blood vessels. These nerves tend to form clusters called ganglions. And so if we feel that this nervous system or that these nerves are playing a role in your pain, the ganglions or areas where the nerves cluster may be injection target points for us. And we do perform lumbar sympathetic blocks and stellate ganglion blocks. So these are examples of sympathetic blocks. The sympathetic nerve block would be a block for pain of the leg or lower extremity. The stellate would be for the arm or hand. Most commonly, we would consider this if someone has a very painful condition called CRPS. That stands for Complex Regional Pain Syndrome. This is a very poorly understood condition that is very, very debilitating for patients. Sometimes it occurs after they've had trauma or nerve damage, and sometimes it occurs independently of that. Commonly, these people will have extreme pain to light touch. They may have swelling, they may have discoloration or temperature changes, and it may affect their movement and strength in that area. We do also offer superior hypogastric plexus blocks and celiac plexus blocks. Most commonly, I probably perform these for cancer pain of the pelvic region, for the celiac plexus, cancer of the pancreas. We would normally inject local and some steroid if someone responds to that. If the patient has a terminal diagnosis, we may try to destroy those nerves further with phenol or alcohol. We can perform these for patients that have pancreatitis flares or chronic pelvic pain with pain flares. Ganglion impar block is an area, is a cluster of nerves near the coccyx or very lowest part of the tailbone. We perform this sometimes for patients that have residual tailbone pain, nerve pain in that area, or sometimes patients that have cancer of the rectum or have had cancer treatment with persistent pain after that. We will commonly perform this. We have some implantable devices that we offer in our clinic. The most commonly used would be the spinal cord stimulator. This is a surgically placed device where thin wires or leads are placed into the epidural space. This is connected to a pulse generator or battery. This generator sends signals to the leads, and this is affecting how signals are sent to the brain and how the brain in turn sends signals back down to that area. There have been a lot of new developments with spinal cord stimulation. Most commonly, the spinal cord stimulator will try to replace the pain with kind of more of a numb sensation. Lately, and more commonly, we're using high frequency techniques or burst pulses. And so we are not replacing the pain with a numbing sensation, just reducing or lowering the pain. There are a number of conditions that we can treat with the spinal cord stimulator. Generally speaking, it's used for nerve-related pain or neuropathic pain, but some conditions that we would use to treat this with would be something called failed back surgical syndrome. This is really a patient that has had back surgery or spine surgery that has persistent pain that is not responding to other means. We would then possibly consider this. CRPS, or that very painful nerve condition that I mentioned earlier, and neuropathies or chronic nerve conditions. There are others, but these would be the most commonly agreed upon indications to use this for. We do use intrathecal pain pumps. This typically does involve a narcotic or opioid. It does not have to, but typically it does. So we would implant a pump or a little generator, typically in the back or abdomen, and this would be connected to a catheter that is placed into the intrathecal space, or the space that has the fluid that bathes the brain and spinal cord. And that generator or that pump would deliver a constant amount of medication into that space. This can allow patients to have a lower dose of medication. The main reason is because we're putting the medication closer to where it needs to bind or closer to where the receptors are. This is not for everyone, but the most common indication would be for poorly controlled cancer pain. That would really be the most agreed upon diagnosis. We do sometimes use it for other conditions, such as failed back surgical syndrome or CRPS, if those patients have not responded to other means and are having very significant poorly managed pain. There is also an intrathecal pump with baclofen. This is used to treat spasticity conditions such as cerebral palsy that can be painful, or spinal cord injuries if there's spasticity that is not responding to oral medications, or if patients are getting side effects from oral medications. And then we have started calling it behavioral therapy. We do have a pain psychologist who has just joined us. Her name is Dr. Kara Klein, and we are thrilled that she has joined us. We have been trying to get a psychologist for some time, and she has started doing therapy called cognitive behavioral therapy. This is basically a common type of talk therapy, I guess, if you will. You work with a mental health counselor or psychologist in a structured way, attending a number of sessions. You would not typically see this person for 5 years or some extended period of time. You would have a defined number of sessions or a finite defined time with some goals that you would set together. But this can help you become more aware of inaccurate or negative thinking that can be associated with your pain. It can change thoughts and emotions and behaviors that are associated with pain and related to pain, and can improve patients' coping strategies and mechanisms. She is currently not offering biofeedback therapy. We don't have anyone at Sanford that is, but we are hoping to change that. She has expressed an interest in this. If we can get the funding to get the equipment, she is planning to offer this. And I think that will be possibly of great benefit to our patients. This is a technique where patients can use to control some of their body's functions, such as your heart rate. Patients are generally connected to some monitors, possibly brainwave activity, their heart rate, blood pressure, how they respond to certain situations or stimuli is monitored. And so then they may tell the patient, well, your heart rate is elevating or your blood pressure is elevating in response to this. So it can make the patient aware of what their response is to those situations, so that they can try to use like breathing techniques or relaxation techniques, etc., when they're exposed to those situations. We do use medication therapy in our clinic. Probably one of the more common ones would be anti-inflammatory medications. These are typically over-the-counter, like ibuprofen, naproxen. These reduce the inflammation in the body. These are commonly used for arthritis, muscle sprain, back and neck injuries. Tylenol is one that we do use some. The mechanism of this is really not known. And then there's another type of anti-inflammatory called the COX-2 inhibitor. This is just a more specific anti-inflammatory, felt to have less negative side effects than the traditional. We do use a number of antidepressant medications. There are different categories of antidepressant medications. The ones most commonly used for the chronic pain specialist would be tricyclic antidepressants or serotonin and norepinephrine reuptake inhibitors. Some examples of the tricyclics would be nortriptyline and amitriptyline, and these are affecting the reuptake of serotonin and noradrenaline in the body, or neurochemicals in the body that can have an impact on pain. Examples of the serotonin and norepinephrine reuptake inhibitors would be duloxetine, or Cymbalta is the other name, then Lifaxine or Effexor is the other name for that. There is pretty solid data to support using these medications for arthritis pain, nerve pain, fibromyalgia, pelvic pain, and facial pain. We do use a number of anticonvulsant medications, specifically like gabapentin or Neurontin would be the other name of that, pregabalin or Lyrica. Commonly, we would use these medications to treat nerve conditions such as like shingles-related pain, diabetic nerve pain. How these work, they appear to interfere with nerves overactively sending pain signals. So basically, in some, you'd be slowing down these nerves from firing. We do use a number of topical medications. Recently, a number of these have become more available to patients over the counter. You can now get topical lidocaine patches, diclofenac, which is a topical anti-inflammatory over the counter. We do work with a compounding pharmacy. They can formulate more concentrated formulations of these medications, and they can also mix 3 or 4 of these medications together. And for some patients, that's more effective. This is best suited for patients with localized pain or very superficial pain. The theory here is that this may have the medication stay more focal or local and not cause as many side effects. So those are some of the positives of these. We do sometimes suggest a TENS unit for a patient. These are just little patches connected by a wire. It sends a little signal. This can help to reduce muscle pain or nerve pain. The patient just puts the electrodes or patches in the painful area. This is something that they can leave on all day and turn it off and on as needed. Insurance does not cover this any longer, but this is something that can usually be purchased for $50 to $100 over the counter. CBD, I did put a couple of slides on CBD and medical marijuana, mainly because there's been so much advertisements for this, and we are so commonly getting asked questions about this from our patients. But CBD is derived from the hemp plant, Most of the time, less than 0.3% of what you're getting will be THC. That's the component that gets people high from marijuana. Our understanding of how this works for patients with pain does continue to grow or evolve. It's felt that it probably interacts and modulates the endocannabinoid and inflammatory systems. So may have some reduction in inflammation. There's really not a lot of human studies on the efficacy of this, and there is no high quality research study supporting the use of CBD alone in chronic pain. Having said that, I've had some patients that have come to me and said this has helped their arthritis pain tremendously. Others have said that it does nothing for them. I just always caution the patient that unfortunately it's not regulated, so you might not know exactly what you're getting from what you're purchasing. And then there's medical marijuana. This is derived from the cannabis plant. So CBD is technically legal federally. Medical marijuana is technically not at this time. There are really different states have approved this. The U.S. Food and Drug Administration has not approved the use as a treatment for any medical condition. There are some studies that report medical cannabis may have a benefit for several conditions, and a few studies that support that it may help with neuropathic or nerve pain. State laws do vary. Possible side effects from it: impaired concentration, drug interactions that we might not know about, and there is potential for addiction. So if patients ask me, is this a good option for me? I usually tell them it may be, but if you have an active substance use disorder, it is probably not. If you have a predilection for a substance use disorder, it is probably not. And if you have a remote history of a substance use disorder, I would try to use some other things to try to manage your pain first. So the ASA statement on this is American Society of Anesthesiology. Their statement on medical marijuana is that much more research is needed to fully understand the risks and any potential benefits using marijuana and cannabinoids, including CBD, for pain management. The ASA supports legislation to expand this research. So that's been one of the issues with medical marijuana and CBD, is just that we don't have a lot of research. Also, there's lifestyle modifications to try to help patients manage their pain. Maintaining a healthy weight has been shown to help patients control their pain. Balanced diet. I'm not here to support someone's book or point out any specific diet, rather just a balanced diet. Activity level, there is pretty solid data that patients that do walk regularly or go for a daily walk can reduce their pain just simply by doing that. And smoking cessation is really huge. Smokers are nearly 3 times as likely to get low back pain as a non-smoker. Smoking is felt to likely aggravate abdominal pain and joint pain. It may increase sensitivity in general in patients. 18% of people in the United States are estimated to smoke, but smokers are probably approximately 50% of the patients that seek treatment for chronic pain. So there is definitely a link there. Regenerative medicine has been something that has been talked a lot about lately. This involves delivering cells or cell products to tissues or organs that are diseased or damaged to restore tissue or organ function. There is viscose supplementation. This has been around for a while. The other name for this is really Synvisc. You're injecting hyaluronic acid into the intra-articular space. The only FDA-approved indication for this at this time is for knee pain. It's felt that this may improve the elasticity of the synovial fluid or fluid around the joint. There's also stem cell injections and platelet-rich plasma injections. We are not currently doing this in our clinic, but there are some private clinics in the area that are. Neither one are FDA approved, but both have been used for conditions such as shoulder, back pain, or rotator cuff injuries. And then there's prolotherapy. Prolotherapy is not FDA approved either. This is really injecting a concentrated glucose solution. You can use this around nerves that are entrapped or use it for painful conditions of the ligaments or tendons. Sometimes we do refer patients to be considered for surgery for their pain. The most common surgeon that we would refer patients to would really be a neurosurgeon. A lot of that is because we are seeing mainly back and neck pain. But a surgeon may or may not decide to perform a discectomy where they just remove part of the disc if it's felt to be pressing on nerves. They may decide to perform a laminectomy or a laminotomy. This just allows the nerves to have more space. They just free up some space around that area. The surgeon may or may not discuss decompression infusion. This is performed to take pressure off pinched nerves, and then hardware is placed in that area to stabilize the spine. And then some of our patients do end up getting joint replacement surgery if they have joint pain that is not responding to other treatments, and if they have moderate or greater arthritis. The mild procedure, this stands for minimally invasive lumbar decompression. We are currently not performing this in our clinic, but we are discussing this. This is used for spinal stenosis. So spinal stenosis is just if a patient has not enough room in their spinal canal region. This procedure would be considered if one of the factors or the main factor is that one of the ligaments is thickened in that area. Then we can go in and remove part of that ligament. And the theory behind how this works is that by removing part of that, we're giving more room for the spinal canal or spinal cord. And then in theory, that should reduce the pain when the patient stands or walks. So patients with spinal stenosis, if they're symptomatic, they're going to have pain when they walk or stand, and it typically worsens the longer that they stand or walk. So my talk today, when I'm discussing these means, I'm not saying that these are the only ways to control pain. This would be a lot of the ways that pain is managed non-narcotically or without opioids in our country. There are other ways to manage pain. I always tell our patients if we can't help control your pain better, I encourage them to seek either some alternative treatments or an opinion with another pain clinic, with a surgeon, or possibly at an academic center, and not give up, because there are new treatments every day, and there may be someone else out there that has a different perspective that can help them. But in sum or overall, there are ways to treat pain without opioids pretty effectively. There is no data to support the use of opioids for non-cancer pain chronically. Opioids should not be used as a first-line therapy in chronic non-cancer pain. We should try other means before we consider that. And if we are going to use opioids for our patients, the patients should be screened, monitored, and maintained on the lowest possible dose that we can maintain them on for safety purposes. Any questions? Yeah. Yeah, we've had quite a few. When I came to the clinic in 2009, I had a colleague who is no longer with Sanford, who prescribed a lot of opioids, really quite excessively. And I don't think that was because he wanted to harm patients. I think it was just because when he trained, that was the train of thought that that's what you did. And so one of my challenges, was a real eye-opener for me, was trying to help these patients get off of these or at least reduce their dose. And an awful lot of them were mad at me initially, but you'd be surprised how many of them, once they did transition to something else, said that they felt better. Oh, sure. I would say at least half, if not even all of them. I mean, we know that most people will get that over time. It's just the exact dose and when, we don't know. When I do procedures on patients, and my colleague too will say this, I clinically know that those patients that are on opioids don't do, they get through the procedure, but they have a lot more sensitivity and discomfort as I'm doing a fairly benign, simple procedure. I mean, I'm having to localize or anesthetize or try to have the nurse distract them or rub their back, or we have some techniques we can try to use to get them through it. So half would probably be a low estimate. I'd say 80% or more. Yeah. Yeah.
Have you seen changes in the way sort of patients arrive at your practice? Like, it seems like those patients
Sure. I think we're still having to do a lot of education, but I think a higher portion of them are coming not wanting opioids or not being on them when they come. And some of them do come for something specific, especially if they know someone that has come to our clinic that's had success, especially if they feel that they have that same type of pain, or they'll say, you know, my sister did really well with that in her hip, I have it in my neck, can you do that? So I think we're seeing patients coming more educated with options.
Do you feel when people come to school, you find that their benefits or their health insurance will cover these such as or is there that area?
Sure, that's a really good question. It depends on the injection. Most insurance companies will cover radiofrequency ablation for like neck and back without problems. Joint radiofrequency can be hard to get covered. Medicare covers that well, so it's really variable, but I would say workers' comp, not to get myself in trouble, they tend to want to cover the opioid and not the interventions or not some of the other treatments. And so we've written a lot of letters and written a lot of appeal letters to them specifically. But on average, they're more apt to want to cover medications than injections, yes. It's frustrating, right? Because it's like there's data that, you know, you can get a side effect or complication from anything in life, right? But we know that these opioids can cause people to become addicted and that some people can be maintained on them without any issues. But with our past history here in the last 30 years, you know, the data is pretty solid, right? That it's causing our country problems. And so you would think that the insurance companies would have looked at that too, but most will cover narcotics pretty readily, at least to a certain dosage. So it's unfortunate, you know, and hopefully that can change. I think it is some, right? I mean, if the opioid prescriptions peaked in 2010, I mean, I've seen a real change since I've gotten here, and patient attitudes about trying to want to get off medications, or not as many of them want to be on as many medications. When I first came to the clinic, there were patients that if they were tired, they wanted me to give them something to keep them up. And if they wanted to go to sleep at night, they wanted me to give them something to help them sleep, and something all day long to just take everything away. And I don't see those type of requests as commonly anymore. So I think we're getting there. You know, we're making progress. Okay, thank you guys. Appreciate your time and having me.